So again, when we treat diabetic, it's not only high blood sugar. Remember, cholesterol, high blood pressure, if you smoke, if you need to take aspirin, especially if you're a man over the age of 40, and some other medication if we need to take them. So it's more than one problem. Sugar is one of the problems. Again, these are very important. Diet, exercise, some weight loss, medications. It could be oral medication, it could be insulin, insulin pump, some patient transplants. So what are the drugs we use for diabetics? We divide these drugs to groups. One group, it increases your own insulin. When you take it, it increases your insulin production, like what we call sulfonylurea, Amaryl, glipizide, glyburide, glucotrol, Brandon, Starlex. These drugs, when you take them, it increases your own insulin. So if someone is having diabetes for 20 years, this won't work because their pancreas is almost dead. There is no insulin production, so taking them is of no value. The second group, it makes your insulin works better in your body. What we call them sensitizers, like metformin, like Actos. Some drugs affect sugar absorption in the GI, in the stomach, like Precoz. The problem is it has too many side effects. Other drugs affect other hormones, like Byetta, Victoza, Januvia, Onglyza, Semlin. And there is some other medication, Wilcol, Cyclocid, just been approved last week. It's going to be in the market next month, actually this week or next week. Of course, always we use insulin, and that's my favorite. Why? Because there is no limit. See, all these drugs, there is a maximum dose. You cannot go beyond the number, except insulin. I can give you 1 unit, I can give you 10,000 units if I have to. There is no limit. If someone tells you insulin is not working, no. It's the doctor and the patient and the dietitian are not working. It's not the insulin. There is something wrong in the team here. Because insulin always works if you take enough from it. So insulin does not fail. All this medication can fail, but not insulin. Because once you take the right amount, it should work. Any questions on the treatment here? Yes.
Well, it's kind of related to this. I have been recently put on like the little insulin pen at night because I've got dawning sugar, and that's where my sugar appears to be the highest. Well, for 2 weeks I got that really sick with the upper respiratory, whatever, and as I was testing my blood sugars were like 170 and 180 with being sick, except no one has ever told me what do I do to try and get those numbers down. Do I take more insulin to try?
You see, that's now it comes to the management. I really cannot give you specific advice because I really don't know you, so.
Yeah.
But usually what I tell my patient is to increase their insulin slowly every day to bring their sugar down.
Okay.
So the best way is to call your doctor, tell him what to do, but they need to go up with your insulin.
Okay.
Now, what are different types of insulin? There is insulin act within a few minutes, what we call rapid acting insulin, like Novolog, Humalog, or Apidra. You take them just before you eat, either within 15 minutes after eating. There is short acting, like regular insulin. There is intermediate acting, like NPH or insulin N. And these two, the R and the N, they are over the counter. You don't need a prescription to get them. And there is the long acting, which acts for 24 hours. The Lantus and the Levemir. I think my guess you're taking one of these two. And then the premix, the mixture of Novolog and the N, or the Humalog or the N. It comes in 70-30, which means 70% is the N, 30% is the Novolog, or 75-25, 75N or 25H Humalog, or 50-50, half NPH, half a Humalog. And which one you take, it depends how your sugar doing. And the doctor should decide which one is the best for you. The most common formula we use is a short rapid acting every time you eat as a patient, and the long acting at night. Because every time you eat, you need a spike of insulin to bring your sugar down. And then between meals, because your body survives on sugar, and after 30-60 minutes, you will have no sugar in your body. So your body produces sugar for you. To keep these down, you need some sugar, some insulin, always in your body. small amount of insulin to keep your sugar steady. Otherwise, your sugar spike between meals. And that's what the long-acting and like Lantus do for you. And that's why some patients, they wake up in the morning, the sugar is high. Why? Because during sleep, your liver will produce sugar for you to keep you alive. And if you have no enough insulin, your sugar will be high. So they give you the long-acting insulin to keep your sugar under control.
And if I'm using the insulin, should I be testing more than once a day?
In your case, probably once or twice at most. Once a day should be enough in the morning. So that's in summary what we do: lifestyle, medication, aspirin, treat the blood pressure, treat the cholesterol. So let's talk about complications now. Diabetes is the leading cause of kidney failure, blindness, limb amputations, gum disease, and of course central nervous system damage. And that's the whole purpose of treating them, is to prevent these complications. The major cause of death in diabetics is cardiovascular disease. About 68% die from heart disease or a stroke. They say that about 50% chance you will have a heart disease at the time of diagnosis. So 1 in 2 diabetic patients will have some kind of heart disease at the time of diagnosis. Almost 75% will have high blood pressure. And of course, if you smoke, it makes things much worse. I will show you 2 studies here to prove to you that really good control can prevent complications. Because that's what we need. We need the proof, right? If we're treating high sugar, I need to show you the proof that it really can make a difference. This one was called DCCT study, was done in the 80s and early 90s. It involved more than 5,000 patients, type 1 diabetic. They developed 2 groups. One gave them regular treatment to keep the sugar okay, and one more intensive control to keep the sugar really good. And they followed them for about 10 years. What they found, controlling sugar is really key to prevent or delay complications. And this is, you can see the number. Lowering the sugar, it decreased eye disease by 76%, kidney disease by 50%, nervous disease by 60%. So good diabetes control can really delay or even prevent complications. Another study now, what we call UKPDS, over 10,000 patients, followed about 15 to 20 years in the 90s and early 2000s, all over the world. The same thing. And this is specifically in type 2 diabetic patients. And this is what they found. Exactly the same like DCCT. Intensive diabetes control, early in the disease, will have much better outcome than loose diabetes control. Again, and they found the ABC of diabetes. You know, A, airway, B, breathing, C, circulation. No. A is A1C, B is blood pressure, and C is cholesterol. That's the ABC of diabetes. Look how much your numbers go down. This is just lowering your A1C 1 point. So if someone A1C is 8, we lower it down to 7, 1 point. Your microvascular disease go down 37%. Microvascular, like your eyes, your kidneys, your nerves, go down 37. Your arteries, 43%. Myocardial infarction, 14%. Stroke, 12%. Heart failure, 16%. Cataract extraction, 19%. That's only lowering your A1C by 1 point. So imagine someone A1C is 10. We lower it down to 7. So it's 3 points. That's 3 times this almost. So that's the proof for you. Good diabetes control will have good outcome. Even though early diabetes control is much better than doing a late diabetes control. What do I mean by that? 2 patients diagnosed today with diabetes. One follow good control from now, then after 10 years become loose. Another one didn't care about it for 10 years, then after 10 years start taking care of it. The first patient, who was really good control from the beginning, will have a better outcome after 20 years than from the second patient who start taking control after a few years. So early is very important, good is very important from the beginning. That's why the moment you have diabetes, don't ignore it. Take good control of it. In 2 months, your sugar is not good, make another change. Let your doctor to make a change. Because early is the idea, is the whole point is early. Early in the management. Don't wait. I don't have some slides. They estimate that a primary care or a doctor on average, they add another drug to a patient after 12 to 18 months. So really, the patients are lazy, the doctors are lazy, and the sugar stays high for long. So you should take an action. If your doctor or your caregiver doesn't care, you care. You look for it, read about it, go and tell your doctor, my sugar is high, I need more action. Don't just ignore it, your sugar is 160. Yeah, slightly high is okay. No, it's not okay. Because we know early control can do much better outcome for you. And that's the message today. Early, early, early. Don't wait till the last second or after 10, 15 years.
In the ABC, what do the A and the B mean?
A is A1C, B, blood pressure, C, cholesterol. You know, airway, breathing, circulation, ABC, in this case.
So all blood pressure.
Yeah, and cholesterol. Because they always come together. Almost all diabetics have high blood pressure. Almost every diabetic should take a cholesterol-lowering agent. And that's what will happen to us in 10 years. So. Think about it. That's what is going on now. You know, almost 60% of the population in this country are overweight or obese. So 60, 65%. Yeah. And diabetic over the, you know, we're getting older population here, so probably within, you know, in some countries, 1 in 3 have diabetes. 1 in 3. So really, remember, early control, take care of yourself, you'll be good in the long run. Just.
So are you saying if you could catch it early enough and monitor it well enough, you could almost always keep it under control? I mean, either add more insulin or...
Yes.
So at what point do you start giving insulin? When
I love it from the beginning. If you ask me as a doctor, see, it depends where you go. If you go to primary care, they keep insulin a little bit late in the disease. If you go to specialists, they like early. Why? Because we have no limit how much we give you. We always can control patients with insulin. Why people don't like insulin early? 20, 30 years ago, we used to threaten patients with it. If you don't do good, I will give you the injection. And they bring a long injection, a scary one. Nowadays, the devices are so tiny, so nice. The needle, you hardly see it. It's painless. I guarantee you it's painless. So that's why we give it early now. And actually, many doctors now follow the trend, early disease. But you know, because the injection, people don't like it early. But usually, we start with metformin. If it fails, another drug, then we give insulin. We don't wait. Your sugar should be controlled within 6 months.
So why does if you have diabetes, why does your pancreas stop? If you've had diabetes for 20 years, why does it
You see, the pancreas dies slowly every year once you have diabetes. And the death rate, it varies between 1 to 6%. So it depends. Some medication can slow down the death. So if someone, let's say, diagnosed with diabetes now, their pancreas is half dead at the time of diagnosis. So you already have half. And if you take this half by 3% or 5% every year, 15 years you have nothing. So that's why oral medication, so all patients, if they live long enough, they will end up taking insulin because their body will have no insulin. So whatever you do, you will end up taking insulin. So what we do in this case, just give it early, take control of your sugar, and be happy.
So might it be your suggestion that if you had a patient like myself who was on Atacan, Actose, and metformin, and a little bit of insulin at night, should we just switch me over to trying to deal with insulin, period?
No, I will try to go up with your insulin first.
Okay. Okay.
But speak with your doctor to make sure how much they want to go up. Okay. Because my guess, the way you're explaining it, it should be fine with just going up with the insulin.
Okay.
I mean, because that's the thing we do. We give the Actose, the metformin, we add the insulin to bring the sugar down, and in many cases, like in your case, we'll be fine. Okay. Sometimes we have to add the fast-acting at dinner time. But it seems you don't need that. It seems that just adding